All right. Thank you, everyone. So today my topic is on the effect of tobacco use on lung function and long-term health. Without any hesitation, I will go into today's topic. So the aims for today is to provide a comprehensive overview on the effect of tobacco use on lung function and long-term health. Oh, I don't know what just happened. Can you still see my presentation?
Yes, I see your presentation.
Okay, all right. Exploring the underlying mechanism, associated diseases, and the transformative potential of smoking cessation, inspiring actions towards a healthier, smoke-free future. All right, moving on. Sorry about that, everybody. I apologize. All right, moving on to my objectives and also the learning outcomes from today's webinar. To identify the key components of tobacco smoke that contribute to lung damage and respiratory diseases, to describe the physiologic mechanism by which tobacco smoke impairs lung function, including its effect on airflow, gas exchange, and airway inflammation. To distinguish between the acute and chronic effects of tobacco use on lung function and respiratory health, to evaluate the evidence linking tobacco use to the development of specific respiratory diseases, specifically asthma, COPD, and lung cancer, and to summarize the benefits of smoking cessation on improving lung functions and reducing the risk of respiratory diseases, and identify effective strategies for supporting tobacco users in quitting. So without any hesitation, we will look at the key components of tobacco smoke that contribute to lung damage and respiratory disease. So tobacco smoking remains a concern and is the leading cause of preventable diseases and death worldwide. Its detrimental effects on the respiratory system are well known for linking tobacco smoke to the development of chronic respiratory diseases. And I've looked at COPD, lung cancer, and asthma, which are the three leading causes for respiratory diseases. The demanding impact of tobacco smoke is primarily due to its complex mixture of chemicals, many of which are toxic and carcinogenic. Understanding the key components of tobacco smoke that contribute to lung damage and respiratory diseases is essential for public health awareness, preventative strategies, and regulatory policies. Now, looking at the composition of tobacco smoke. Tobacco smoke is basically a mixture of several chemicals, and it consists of over 7,000 compounds. This includes gases, volatile chemicals, and particulates. So when tobacco burns, it releases these chemicals in two major forms, either as mainstream smoke, which is inhaled directly by the smoker, or it does it via side stream smoke or secondhand smoke, which is emitted from the burning tip. Both forms are harmful, but side stream smoke contains a higher concentration of many toxic substances. Now, of those 7,000 plus chemicals that are found in tobacco smoke, some are very common and are identified as leading cause for respiratory lung health, respiratory decline or lung health decline. So of those are nicotine. Now, nicotine is primarily known as the addictive component of tobacco. So, but in addition of being an addictive component, it also contributes to inflammation and oxidative stress, which contribute to tissue injury. Nicotine also stimulates mucus secretion and constricts the small airways, thus reducing airflow. It is not directly a carcinogen, but it does lead to lung cancer. The reason behind is because of its additive effect, being an causing addiction, causes the person to use tobacco longer and so expose them to the carcinogens that are found in tobacco. Tar is a sticky black substance that results from the incomplete combustion of tobacco. It contains numerous carcinogenic chemicals and many irritants that directly damage the lining of the airways or the respiratory epithelium. The accumulation of tar in the lungs basically coat the airway surface and impair ciliary function. The the cilia are there to clear mucus and debris. When this is damaged, it leads to increased mucus production, inflammation, and also the destruction of alveolar tissues. Carbon monoxide, this is a colorless and odorless gas that binds strongly to hemoglobin, and when it does, it displaces oxygen, thus decreasing the oxygen carrying capacity of the red blood cells, which leads to tissue hypoxia. Formaldehyde and other aldehydes, they cause reactive chemicals, which causes direct injury to the lung tissue. They are potent irritants that cause inflammation, edema, and damage to the airway and alveolar cells. Formaldehyde is also classified as a human carcinogen, contributing to lung cancer risk. Ammonia. Ammonia enhances the absorption of nicotine and other chemicals in the lungs, increasing their harmful effects. Benzene and polycyclic aromatic hydrocarbons, which is also known as PAH, are carcinogenic compounds present in tobacco smoke. And what they do, they induce genetic mutation in lung epithelial cells, leading to the formation of lung cancer. Now, the mechanism of lung damage. The harmful chemicals in tobacco smoke induce a cascade of damaging processes. First, you have inflammation from the exposure of the smoke. Many chemicals will also stimulate inflammatory response. This leads to airway edema, increased mucus production, and the destruction of the alveolar walls. Oxidative stress, reactive chemicals generate free radicals, causing oxidative damage to lung tissues, DNA, and protein, and this causes cellular injury and cell death. DNA damage and carcinogenesis. Carcinogens in tobacco smoke induce mutation in lung epithelial cells, leading to the development of lung cancer. Ciliary dysfunction. The tar and irritants from the burning of tobacco impairs the cilia's ability to clear mucus and debris, resulting in bacterial colonization of the airway, chronic bronchitis, and increased risk of recurrent infection. Alveolar destruction. You have the enzymatic degradation of the alveolar walls. This is driven by chronic inflammation and oxidative stress, and it results in emphysema and a decrease in gas exchange capacity. Now, to look more in depth of all of those mechanisms, specifically focusing on airflow, gas exchange, and airway inflammation. So you have the destruction of airflow dynamics, and this is from acute bronchoconstriction with just exposure to the tobacco smoke to chronic exposure, which leads to airway remodeling. So acute bronchitis. Acute bronchoconstriction. So tobacco smoke contains irritants and inflammatory agents that rapidly induce bronchoconstriction. This is a narrowing of the airway due to the contraction of submuscles which wrapped around the bronchioles. Nicotine stimulates the release of acetylcholine at the neuromuscular junction, and this activates the muscarinic receptors on the airway smooth muscle. This activation triggers signaling cascade of events that increases intracellular calcium, resulting in the contraction of the smooth muscles. When the smooth muscle contract, you get decrease in the size of the diameter, which results in increased airway resistance and reduced airflow. The prolonged exposure to tobacco smoke induces structural changes in the airway, which is also known as airway remodeling. In epithelial cell damage, the initial insult of tobacco smoke causes damage to the epithelial cells lining the airway. The smoker's irritants and toxins disrupt the integrity of the epithelial barrier, which lead to increased permeability and inflammation. In subepithelial fibrosis, The chronic inflammation tissue damage promotes the deposition of extracellular matrix protein, such as collagen and fibronectin, in the epithelial layer. This thickens the airway wall, making it less flexible and further narrowing the airway. For smooth muscle hypertrophy, this occurs from prolonged exposure to tobacco smoke, which stimulates both hyperplasia and hypertrophy of the airway smooth muscle, and this increase in smooth muscle bulk or mass exacerbate airway constriction and also contribute to airflow limitation. And lastly, increased mucus secretion. So tobacco smoke stimulates hyperplasia of the goblet cells. The goblet cells are specialized epithelial cells which produces mucus. This leads to increased mucus secretion, further narrowing the airway and impair mucociliary clearance, which is a natural process that the lungs uses to remove mucus and debris. Impaired gas exchange. So the alveolar structures responsible for efficient gas exchange in the lungs are particularly vulnerable to the destructive effect of tobacco smoke. The protease-antiprotease imbalance occurs when tobacco smoke disrupts the balance between protease, which are the enzymes that degrade proteins, and antiprotease enzyme, which are the enzymes that inhibit protease. It works specifically at the release of protease such as elastase and matrix metalloproteinases, or the MMPs, which are produced from the neutrophils and macrophages. These are immune cells that infiltrate the lungs in response to chronic inflammation. While it is doing that, it is also simultaneously, the tobacco smoke inhibits the function of alpha-1 antitrypsin, and we know this is a key antiprotease that normally protects the alveolar wall integrity from enzymatic degradation. Now, this imbalance leads to an excessive breakdown of elastin, which is a critical component in maintaining alveolar structure. Now, the unchecked activity of elastase and MMP will lead to coalescence of the alveoli into larger, less efficient air sacs. And when that happens, it reduces surface area for gas exchange in the alveoli. For elastic recoil, the breakdown of the elastin also impairs the elastic recoil of the lungs, which is essential for maintaining airway patency during exhalation. This loss of recoil contributes to airway collapse and air trapping, which further exacerbate airflow limitation and impairs gas exchange. And lastly, airway inflammation. So chronic airway inflammation is the hallmark for asthma and COPD in smokers and is a critical mediator for lung damage caused by tobacco smoke. This inflammation involves a complex interplay of immune cells, inflammatory mediators, and structural changes in the airway. So the tobacco smoke triggers the recruitment and activation of various immune cells in the airway. This would include your neutrophils, your macrophages, your T lymphocytes, and eosinophils. These cells release a set of inflammatory markers that amplify the inflammatory process and worsens lung damage. The activated immune cells release an array of inflammatory mediators. This would include cytokines, tumor necrotic factors, interleukins, your reactive oxygen species, and chemokines. These mediators contribute to several pathologic processes, which include increased vascular permeability. And this results into edema and contributing to airway narrowing. Hypersecretion, which is the cytokines, stimulates the goblet cells to proliferate and produce more mucus. So it's hypersecretion of mucus as well as impaired mucociliary clearance. It also causes disuse destruction. So your reactive oxygen species and the protease, which is released by the immune cells, cause oxidative damage and breakdown of the extracellular matrix proteins. This contributes again to alveolar destruction and airway remodeling. You have the oxidative stress. So the tobacco smoke generates a significant amount of free radicals, as well as your reactive oxygen species. And this overwhelms our lungs' natural antioxidant defenses and causes stress, which damages lipids, proteins, DNA, etc., and further fuel inflammation and lung injury. And all of this basically creates an application loop. So you continue to smoke, which will result in persistent exposure to the tobacco smoke. This sustains the activation of the immune cells. You're sustaining the release of inflammatory mediators and leads to continuous destruction of the lung tissue and progressive lung decline and in lung function and lung health. Now, moving on to the acute and chronic effect of tobacco use on lung function and respiratory health. Tobacco use, primarily through smoking, remains a major public health threat worldwide, significantly impacting respiratory health. You will agree with me that a respiratory system constantly exposed to the environment is particularly vulnerable to the numerous harmful substances present in tobacco smoke. These substances initiate a cascade of immediate and delayed effects, leading to a wide spectrum of respiratory ailments or conditions. Understanding the difference between acute and chronic effects of tobacco use is critical when designing effective prevention strategies, educating individuals on the damages of smoking, and developing appropriate therapeutic interventions. Now, the acute effect of tobacco use refer to the immediate and short-term responses that occur within minutes to hours of exposure to tobacco smoke. These effects are primarily transient and reversible, though they set the stage if tobacco use persists for long-term damage. You have airway irritation and inflammation. Now, inhaling tobacco smoke causes immediate irritation of the airway due to the presence of irritant chemicals such as formaldehyde, ammonia, etc. These compounds directly stimulate sensory nerve endings in the respiratory tract, triggering coughing, wheezing, chestitis, and sometimes even shortness of breath. The acute inflammatory response, the irritants in the tobacco smoke activate inflammatory cells, as I mentioned before, the neutrophils and the macrophages in the airway. And these cells release mediators, such as your cytokines, your reactive oxygen species, etc., that leads to increased vascular permeability, swelling of the airway, and mucus production. This acute inflammatory response causes temporary airway narrowing and increased resistance to air flow. Bronchoconstriction. As I mentioned before, nicotine stimulates the release of acetylcholine at the neuromuscular junction, activating muscarinic receptors on the airway smooth muscles, and this leads to bronchoconstriction as well as decreased airflow. The reduced airflow, particularly during exhalation, make it difficult for individuals to breathe deeply. This results in, again, shortness of breath, coughing, wheezing, chestiness, even in somebody who does not have a pre-existing lung damage or lung condition. Increased mucus production to the goblet cells. Stimulation. This irritants in tobacco smoke stimulates the goblet cells to increase mucus secretion. While mucus helps trap and clear foreign particles, excess mucus production can obstruct the airway and impair mucociliary clearance, the natural mechanism in which the lungs remove mucus, which I mentioned earlier. Now, the cough reflex activation happens because there is now excess mucus inside of the airway, and also from the irritation from the tobacco smoke will trigger off the cough reflex in an attempt for the body to clear its airway or clear the mucus from the airway. Now, it's a circle because when you start coughing now, and frequent coughing can further irritate the respiratory tract and contribute to additional mucus production. Nicotine stimulates the sympathetic nervous system, which leads to increase in heart rate, increase in blood pressure, and increase in cardiac output. These changes have an effect or an additional strain on the cardiovascular system. In addition to that, carbon monoxide exposure displaces oxygen on the hemoglobin, which further decreases the oxygen carrying capacity of the blood and put a further strain on the cardiovascular system as well. Temporary immune suppression from acute exposure to tobacco smoke can suppress immune function in the respiratory tract and increase the risk for a respiratory tract infection or recurrent respiratory tract infection. Okay, the effect of tobacco smoke on lung function and respiratory health. The chronic effect of tobacco use results from prolonged exposure to tobacco smoke over years or decades, leading to irreversible structural and functional changes in the lungs and the airways. Now, the first condition looked at will be COPD, chronic obstructive pulmonary disease. COPD is a progressive lung disease characterized by chronic inflammation leading to irreversible airflow limitation. Now, COPD is an umbrella term which covers two conditions, chronic bronchitis and emphysema. You can have either or both. Chronic bronchitis is long-term inflammation and irritation of the bronchial trees, cause persistent coughing and mucus production. This chronic inflammation leads to thickening of the bronchial walls, increased mucus secretion, and impaired mucociliary clearance. Emphysema, on the other hand, involves the destruction of alveolar walls, leading to the enlargement of air spaces distal to the terminal bronchioles. This reduces the surface area available for gas exchange and impairs elastic recoil, resulting in air trapping and further airflow limitation. Chronic COPD, chronic obstructive pulmonary disease, decline can be measured using spirometry. Now, this here is showing you just an overview of chronic bronchitis and emphysema. So in chronic bronchitis, you can see the nice healthy airway, nice clean, and then you can see all the changes that happen to the airway in chronic bronchitis. So you can see inflammation, you can see swelling, you can see reduction in your airway diameter, and further reduction of that airway diameter because of a lot of mucus being present there. And then emphysema, you see your nice alveoli, and then with alveolar destruction, you can see a reduce in alveolar membrane. And when that is reduced, you have decreased surface area for gas exchange. There is also decreased elastic recoil and compliance of the alveoli, which will result in air trapping. Lung cancer. So tobacco smoke contains numerous carcinogens, and these substances cause DNA damage, genetic mutations in the lung epithelial cells, which leads to uncontrolled cell growth and tumor formation. Cellular changes that take place, the chronic exposure to tobacco smoke results in cellular changes such as dysplasia and metaplasia, which can progress to invasive lung cancer. And over time, accumulated genetic mutation can lead to the formation of cancer tumors in the lungs, and this can metastasize to other parts of the body. Asthma, exacerbation and development. So in asthma, tobacco smoke can cause airway hyperresponsiveness, and this puts the individual at risk because of the hypersensitiveness of the airway, puts them at risk for increased sensitivity to allergen, irritants, cold air, and thus causing frequent and severe asthma exacerbation. You can also have inflammation and remodeling. So smoking exacerbates airway inflammation and promotes airway remodeling in individuals with asthma. This leads to increased mucus production, airway wall thickening, and note irreversible airway inflammation. Lung fibrosis involves the excessive accumulation of fibrous connective tissue in the lungs. Chronic inflammation and oxidative stress caused by tobacco smoke stimulate fibroblasts to produce collagen and other extracellular matrix proteins, leading to the stiffening compliance, the lung compliance and out. Sorry about that. All right, impaired immune defense. So long-term smoking impairs the function of immune cells in the lungs, reducing their ability to clear pathogens and fight off infections, which leads to recurrent pneumonia and bronchitis, which is commonly seen in COPD patients as well as those who are smoking. Now, this here is a table that summarizes the acute effects as well as the chronic effect with airflow, gas exchange, inflammation, cardiovascular involvement, immune function, and reversibility with the effect of smoking on lung. Now, we have claimed all of these effects where smoke is causing detriments to lung health. On reviewing of the literature, tobacco use predominantly in the form of cigarette smoking has long been recognized as a significant risk factor for a multitude of health problems, with respiratory diseases topping that list. The association between tobacco smoke and specific respiratory ailments such as chronic obstructive pulmonary disease, asthma, and lung cancer has been extensively researched, providing a wealth of epidemiologic, clinical, and experimental evidence. Understanding the nature and strength of these associations is critical for public health initiatives aimed at preventing and managing these diseases. So with regards to the literature and COPD, the connection between tobacco smoke and COPD is perhaps the mostly firmly established among respiratory diseases. Numerous epidemiological studies have consistently demonstrated a strong association between smoking and COPD. These studies show that smokers have a significantly higher risk of developing COPD compared to non-smokers, and the risk increases with the duration and intensity of smoking. The Farm-Hamlin Heart Study and the Physicians' Health Study have tracked large cohorts of individuals over years, several decades, providing robust evidence that smokers are more likely to develop COPD. These studies show a dose-response relationship, meaning that the risk of COPD increases with the number of cigarettes smoked per day and the number of years of smoking. Case control studies also compared individuals with COPD with those without COPD to identify risk factors. These studies consistently show that a higher proportion of COPD patients have a history of smoking compared to controls. Asthma and tobacco use. So asthma is not solely caused by smoking. There is a significant evidence that it impacts its development and severity in exacerbation. Studies have shown that women who are pregnant and smoke or children who are exposed to secondhand smoking increases their risk of developing asthma. Smoking also worsens asthma symptoms. If you have asthma and you smoke, or you have asthma and you're exposed to secondhand smoke, it worsens asthma, makes increased frequency of exacerbation, greater airflow limitation, and it also decreases your response to asthma medication. There is also higher hospitalization rates. So individuals with asthma who smoke are more likely to be hospitalized for their conditions compared to non-smoker with asthma. So these are persons who are going to have to be using increased rescue medication. They have increased ER visit, increased admissions, increased unplanned visit to their physician's office, and also missed days from work or school. Now, all of this happened, excuse me, because of the airway hyper responsiveness. So tobacco smoke, as I mentioned before, increases the sensitivity to allergens and irritants and cold air. So the asthma is easily triggered off. Inflammation and remodeling. Smoking promotes airway inflammation and remodeling in individuals with asthma. And remodeling asthma leading to increased mucus production and airway wall thickening and irreversible airflow. And also, you have reduced response to corticosteroid because you're smoking and you're using the medication, or the asthma has worsened where you have remodeling, and so you're not getting that response to your corticosteroid as normally do. Tobacco use and lung cancer. So lung cancer is one of the deadliest cancers globally, and tobacco smoke is unequivocally is a leading risk factor. The association between smoking and lung cancer is one of the strongest and most extensively studied relationships in medical science. The British Doctors Study and the American Cancer Society cancer prevention study have followed large cohorts of smokers and non-smokers over decades, demonstrating a substantial increase in lung cancer risk among smokers. These studies have established that the risk of lung cancer increases with the number of cigarettes smoked, the duration of smoking, and the age at which smoking begins. There is also the case control studies which consistently show that a higher proportion of individuals diagnosed with lung cancer have a history of smoking when compared to control. These studies also indicate a dose-response relationship between smoking and lung cancer. Statistical analysis estimated that tobacco smoking is responsible for approximately 80 to 90% of lung cancer cases. Clinical observations have also identified tobacco smoke to contain over 70 known carcinogens. These carcinogens damage DNA, leading to mutations in genes that control cell growth and differentiation. These mutations disrupt the normal cell regulation, causing uncontrolled cell growth and tumor formation. And there is also the molecular biology studies, which have identified specific genes that are frequently mutated in lung cancer, and these mutations have been linked as well to tobacco smoke exposure. Now, the evidence linking tobacco to respiratory disease is very overwhelming and compelling. This is just a brief overview linking the evidence to respiratory diseases. While the precise mechanism vary for each disease, the consistent presence of airway inflammation, impaired lung function, and DNA damage underscores the profound and far-reaching effects of tobacco smoke on respiratory health. Effective public health strategies should focus on tobacco use prevention, smoking cessation, and mitigating exposure to secondhand smoke to reduce the global burden of these debilitating conditions. Promoting smoking cessation through educational initiatives, behavioral therapies, and pharmacologic interventions offers significant potential to improve respiratory health outcomes and reduce healthcare costs associated with these diseases. Given the overwhelming evidence, continuing to address tobacco use remains a critical priority for respiratory health worldwide. Now, moving on to the benefits of smoking cessation on improving lung function and reducing the risk of respiratory diseases and identifying effective strategies for supporting tobacco users in quitting. Now, tobacco use, primarily cigarette smoking, remains a pervasive and preventable cause of morbidity and mortality worldwide. While the harmful effects of smoking are well established, the benefits of smoking cessation are equally profound, offering significant improvement in lung function and a substantial reduction in the risk of developing chronic respiratory diseases. As such, supporting tobacco users in quitting is paramount to enhancing public health. Let us support tobacco users in their journey towards a smoke-free life. Now, quitting smoking initiates a cascade of beneficial effects on the respiratory system, leading to improvements in lung function and overall respiratory health. Improved airway and reduced airway obstruction via reduced bronchoconstriction, decreased inflammation, and enhanced mucociliary clearance. It improves lung elasticity by reduced elastin degradation and decreased air trapping. It enhances exercise tolerance by improving oxygen delivery and reduce respiratory muscle fatigue. It will enhance your immune function by increasing immune cells activity, decrease susceptibility to infections, and reduce the risk of respiratory diseases. So everything that I would have mentioned earlier as the mechanism for all of these pathophysiological changes that occur with cigarette smoking, once you stop, you have everything gradually reversed. To some extent, some are irreversible, which we will cover just now. So beyond improvements in lung function, smoking cessation significantly reduces the risk of developing chronic respiratory diseases and improves overall respiratory health. So looking at COPD, it slows the disease progression, it reduces exacerbation, and it improves survival. Now, it doesn't reverse COPD completely, but it slows the progression of COPD and preserve the lungs as it is. In lung cancer, it reduces your cancer risk And if you have cancer, it improves your prognosis. In asthma, it reduces airway hyperresponsiveness, resulting in better symptom control. And it reduces your risk as well for respiratory infections as the airway can now clean itself properly, remove mucus and the cilia, and everything could work comfortably. Now, immediately after someone stops smoking, within 20 minutes, you can start to see benefits. Blood pressure, pulse rate, reduced temperature in hands and feet return to normal. Within 8 hours, your carbon monoxide and oxygen level in the blood returns to normal. Within 48 hours, the nerve ending starts to regrowing. Ability to smell and taste is enhanced. Within 2 to 12 weeks, circulation and breathing improves and walking becomes easier. Within 1 to 9 months, decrease in coughing and sinus congestion and shortness of breath. There's increase in overall energy and lung ability to self-clean and reduce infection. Within 1 year, there is excess risk of coronary heart disease in half that of a smoker. Within 5 years, stroke risk reduces to that of a non-smoker. Risk of cancer in any part of the body, half that of a smoker. Within 10 years, life expectancy comparable to a non-smoker. Lung cancer death rate is about half the rate of smoker. And precancer cells are also replaced. And by 15 years, your risk of coronary heart disease is comparable to that of a non-smoker. Now, how do we get them to stop smoking? So supporting tobacco users in quitting requires a multifaceted approach to address both the physical and psychological aspect of addiction. So you have behavioral counseling. This can be done using individual counseling. This is a one-on-one counseling with the healthcare professional and the person. And then you have group counseling where you have group sessions that offer a supportive environment where individuals can share their experience, share their learning, their coping mechanisms, and how to control craving and their steps that they did to stop smoking. And they can also provide encouragement to each other. There is also pharmacologic intervention where you can use nicotine replacement therapy, NRT. These are available in various forms. You have them in nasal spray, inhalers, patches, etc. NRT helps reduce withdrawal symptoms by providing a controlled dose of nicotine without the harmful chemicals that are found in tobacco smoke. And if NRT fails, you also have bupropion and varicellin. These medications help reduce cravings and withdrawal symptoms. They act on a neurotransmitter in the brain and help to alleviate nicotine addiction. And you can also do combination therapy where you combine both counseling and pharmacotherapy. There is also community-based programs where you have workplace programs where the workplace implement programs that help persons to stop smoking and promote a smoke-free work environment. And then you have community outreach, where community-based initiative can reach a broader population by providing education, counseling, and resources to help individuals quit smoking. You also have digital intervention where you can have mobile apps. These can send personalized support. They track your progress, they offer reminders, and they develop motivational messages to keep motivating you to quit smoking. And then you have the World Wide Web, where you have online resources in all form where you can access on quitting smoking. Now, motivational interviewing, which is a patient-centered approach, is helps individuals to explore their ambivalence about quitting and identify their personal reasons for change. This technique can increase motivation and readiness to quit smoking through the BTI, which brief tobacco intervention, which I will revisit in a few. Now, in addition to all of these, you also need policy intervention. So you need smoke-free policies, which implement smoke-free policies in public places, workplaces, and even in homes. So it reduces exposure to secondhand smoke. Tobacco taxes. Increasing taxes on tobacco products increases cost for it and will deter persons from purchasing these products. Advertising and marketing. Put strong restriction on advertising and marketing of tobacco products and do not support tobacco products. Don't have them support researches and all of these things. brief tobacco intervention. So the brief tobacco intervention is basically spending 3 to 5 minutes with your patient. This could be done by the physician, by the asthma COP educator, by nurses, by respiratory therapists, anybody on the floor once they know how to do the BTI. So in the BTI, you're looking at the 5 A's to smoking cessation, where you ask, advise, assess, assist, and arrange. In ask, once you have confirmation that this person smoke, you ask, what do you smoke? How much do you smoke? And how long do you smoke? And then you advise them on the harms of smoking and the importance of um, quitting. Now, it's a one-on-one discussion, and it's not where the healthcare professionals is um, loading off all of the information on the patient. It's a discussion session, so you can ask and let the patient tell you what is the harmful effect of tobacco use and why is it important to quit. And then you can assist by giving them the additional information. After that, knowing that they have all of the knowledge, the next thing to do is to assess their willingness to quit. Now, this is the point in which some may say, yes, they're willing to quit, but others may say they're not willing to quit. If you're not willing to quit, then you move on to the 5 R's, which we will cover in a few. If they are willing to quit, then you provide assistance. So in so doing, you create a quit plan with a date. Oh, many studies would say within a few days, some say a week, but definitely not more than 2 weeks should this quit date be established. During that time, you advise them to get rid of all their tobacco products, as well as anything associated with the use of tobacco, such as their lighters, ashtrays, these things. Tell their family and friends that they want to quit so that they can get that support. Explain to them to break habits. So some person have habits, like for example, when they're taking coffee break, instead of taking their coffee, they go and they smoke. So they have to break that habit, or else when the time comes, they're gonna get the natural urge to go and smoke. So they have to break habits. And you also explain to them on the craving, intensity of the craving, especially within the first 48 hours, and explain to them that these cravings are going to be far apart and less intense once they keep up, not going back to using the cigarettes or the tobacco product. And once that is clear, then you can arrange for follow-up, usually within 1 week of the quit date. Now, if they said no, they're not willing to quit, then you go to the 5 R's and basically try to find out why is it that they're not quitting? What are their roadblocks? What's preventing them from quitting? So relevance, encourage patients to indicate why quitting is personally relevant, being as specific as possible to that particular patient. Identify the risk. Ask the patient to identify potential negative consequences of smoking that are personally relevant. And rewards. Ask patient to identify potential benefits of stopping tobacco use and highlight those that seems most relevant. Roadblocks. Ask patients to identify barriers to quitting and discuss potential solutions that address these barriers. Now, after roadblocks, and if you get over the roadblocks with the patient, then you can go back to assess willingness to quit. And if they say yes, they are now willing to quit, then you move on to assess and arrange. If they said no, that they're not willing to quit, then that's okay. Leave it as it is and revisit the topic on the next visit. Now, this here is the screening tool that you can use as well to indicate how dependent is the person on nicotine. It basically guides management, so it can able to tell you if this person can do well with just counseling alone because they smoke once and far apart, or if this is a person who may probably have to do dual therapy, etc. Now, even though vaping and lung health, this topic is related to this, but I put it separate because it's becoming a health concern. Um, so vaping, which is using electronic cigarettes or e-cigarette, has surged in popularity, particularly among our younger generation, the adolescents and teenagers, as a perceived safer alternative to traditional cigarettes. However, mounting evidence suggests that vaping is far from harmless and poses significant risk to lung health. E-cigarettes, heat liquid, which is the e-liquid, to create an aerosol that users inhale. While often marketed as delivering just nicotine, e-liquids and the resulting aerosols contain a complex mixture of substances that can harm the lungs. And these include nicotine, which has also the same effect in e-cigarette as it did in traditional cigarette. It also, in addition, have propylene glycol and vegetable glycerin. And these are base solvents in e-liquids that produce the vapor, the big smoke that you see when they're vaping. And when heated and inhaled, they can irritate the airway and have been linked to acute respiratory distress. Long-term effect is still unknown. And the flavoring in these e-cigarettes. So flavoring added to e-liquids enhance appeal may contain diacetyl. Diacetyl is known to cause bronchiolitis obliterans. It's a rare lung disease, but it's now showing up because of the use of diacetyl. This condition is also known as popcorn lungs. Other chemicals in e-cigarette includes heavy metals such as nickel, chromium, lead, manganese. It also contains ultrafine particles, also known as particulates, and these, as I mentioned earlier, they penetrate the lungs because they're very, very tiny. They penetrate the lungs, causing induced oxidative stress, inflammation, and cellular injury. Now, the acute effects of vaping is similar to that with the burning of the tobacco and using the traditional cigarette, which is airway inflammation, bronchoconstriction, increased mucus production, and impaired immune response. With regards to chronic effects, similar results, COPD, asthma exacerbation, increased risk of respiratory infections, lung cancer, pulmonary fibrosis, and with the addition of bronchiolitis obliterans or popcorn lungs. Now, what makes vaping different from traditional smoking? So vaping is often promoted as a safer alternative to traditional smoking, but this claim requires careful consideration. While e-cigarettes may contain fewer harmful chemicals than traditional cigarettes, they still deliver a range of toxic substances that can harm the lungs. Nicotine delivery, the e-cigarettes has a higher dose of delivery of nicotine as compared to traditional cigarettes, which makes it even more addictive. Flavorings and solvents. Unique to vaping are the risks posed by flavoring chemicals and solvents like your propylene glycol and vegetable glycerin. And we still don't know the long-term effect of these chemicals on the lungs or general health. And then there are people who use dual use of it. So they use both e-cigarettes and they also use a traditional cigarette, which doubles your risk because now, in addition to all of the chemicals you're exposed to in traditional smoking, you're also now exposed to flavoring and solvents. In concluding, smoking causes both short-term and long-term respiratory health risks, but can affect almost any organ in the body. Smoking cessation offers profound benefits for lung function and significantly reduces the risk of developing serious respiratory diseases. By quitting smoking, individuals can improve their airflow, enhance lung elasticity, reduce inflammation, and strengthen their immune function. Successfully supporting individuals through their smoking cessation journey requires a comprehensive approach to combine behavioral counseling, pharmacological intervention, community-based program, and policy measures. Though concerted efforts to promote quitting and to provide evidence-based support, it is possible to substantially improve the respiratory health of individuals and communities. Ultimately, a concerted effort combining individual support, community action, and effective policies is essential to improve respiratory health and reduce the global burden of smoke-related illness. These individuals, they cannot do it alone. They need our help. And to end today's webinar, World No Tobacco Day is celebrated on the 31st of May. Let's all join to say no to smoking tobacco under the theme Unmasking the Appeal, Exposing Industry Tactics of Tobacco and Nicotine Product. Thank you, everyone.
Thank you, Dr. Walima Ali Bacchus. Thank you so much. And kindly post your questions in the Q&A session. Thank you. Okay, so as I said earlier on, this webinar series is brought to us by Zopec Medical, and Zopec Medical is a company that manufactures the world's smallest battery, which supports transporting of the critically ill patient with no interruption in power supply. They ensure or enhance physical therapy, respiratory therapy, seamless patient transport, early mobility of this patient, and these batteries are compatible to the numerous medical devices in the hospital facility. So Zopec Medical, as they say, empowering or powering critical mobility with confidence. That is their theme. So if you want batteries or you want batteries to support your equipment whilst giving care to your patient, contact Zopec Medical on www.zopec.medical.com or contact the Africa Respiratory Care Association at info@africaresp. I will also post at the end of the webinar, if you are in Africa and you need these batteries, I'll post the country rep's contact so that you can directly contact him. He is in South Africa, and that will be easy for you to get. But if you are participating from outside Africa, you can always reach them on their website. Thank you very much, Dr. Walima Bacchus, for this insightful segment. Now we switch to the Q&A. I'm ready to read your questions now. If you have any questions for Dr. Walima, kindly post your questions now so that we can read it out. Q&A. Okay, so from Ebenezer, he says, can tobacco smoke also affect the kidney?
So tobacco smoke can basically affect any part of the body. It can affect the kidney, it could affect the heart, it could affect the eyes, the oral mucosa, everywhere. But because we're focusing specifically on respiratory health, I kept this webinar directly to lung health. However, yes, it can affect kidney health,
Yeah, so the
causing
same,
acute kidney injury.
right. Ebenezer again says, can a patient recover fully from tuberculosis after smoking for more than 30 years and decides to stop smoking?
So they can, it all depends on the extent of whatever damage had occurred to the body from tobacco smoking. So there are immediate benefits from quitting smoking, such as regulation of your heart rate, your blood pressure, and these things, right? Airway clearance, you stop coughing, you're breathing more comfortable. Um, and those are immediate effect, like within minutes to days to weeks. Um, However, if you have certain damage, for example, COPD or the same kidney damage, if the damage has already been made, you cannot reverse these damage. They're permanent damage. But by quit smoking, it prevents progression of the damage. So the condition is not going to get worse. It gets arrested where it's at. It doesn't worsen, providing the person would have quit smoking. So
Okay.
there are evidence where persons smoke for prolonged period and they haven't developed any damage, and well, good for them. And that's the best time in which for them to quit. Or they now start to develop some acute problem, like they now start to get
Hello. And he has to follow my instructions very, very carefully. Dr. Walima, can you hear us? Hello, Dr. Walima, we lost you at the point. You
Hello?
are mute. Yes, we can hear you now. So I continue with the questions, and someone is asking, so how about people that have smoked over the years yet have not experienced lung problems, but some others start smoking in some few times and they get lung problems? Are there predisposing factors that makes other people less exposed while others are exposed?
So that is true. There are people who would have smoked for a very long time or used tobacco product for a very long time and there's no effect. Whereas some persons just started for a few months or a few years and they start to have it. There is predisposition. Everybody reacts differently to a trigger or to a exposure to an irritant. And there is also genetic factors that influences the development of developing these lung conditions.
Okay. All right. Then anonymous participant says, how does the vaping damage the lungs and hookah, meaning vaping and hookah, how does it really damage the lungs?
So I covered that in the presentation just now.
Yes.
The smoke from all of these, they enter the lungs and they cause airway inflammation. Airway inflammation also causes, in addition of airway inflammation, it also causes swelling of the airway or edema of the airway. It causes hyperstimulation of a specific type of cells in the airway, which are called goblet cells, and they produce a lot of mucus. It also inhibits the natural mechanism of the lungs, the mucociliary pathway, to clear secretions, and that will also lead to increased mucus. When these are there, the lungs doesn't clear itself as normally as it should, and it increases infection. It causes, and it eventually can lead to colonization. Now, chronic inflammation would eventually lead to oxidative stress. It would also lead to cellular injury and permanent remodeling of the lungs. So you have all of these extracellular matrix are now going to go and deposit into the lungs and makes all of these changes not irreversible. So the lungs is just going to become stiff, the airway is going to become stiff, the lungs is going to become less compliant. And that's when you start to develop all of these symptoms like your shortness of breath, your coughing, your wheezing, the chest tightness, etc.
Okay. Well, Maha in Chad, he said, thank you a lot, Dr. Bibi. What's the first thing you usually look for in a patient's history when you suspect tobacco-related lung issues?
So as part of any patient who's presenting to you, as part of their history, you're supposed to do exposure history and that or social history, which would include their history in smoking. So from there, you see, you can tell if the person is currently smoking, if they smoke in the past, how long they smoke for, what they're smoking. Any patients who present to you with respiratory condition presents with the common symptoms of shortness of breath, coughing with or without mucus, fatigue, maybe recurrent respiratory tract infection, progressive shortness of breath. These are common findings. By just their presentation, you cannot tell that, okay, this is caused because of tobacco. But through their history, you can tell if this might possibly be caused because of tobacco. And so, and the first test that you would order is your chest x-ray, which can show you tobacco related changes on your x-ray. And you can further compound that with your CT scan to confirm the changes and compare that if it's associated with tobacco related injuries.
Okay, thank you. And from Rekia is asking about, she said, can you kindly, okay, I think this goes to Zopec Medical. Can you kindly talk more about the batteries you have mentioned earlier? Okay, so Rekia and anyone who needs to know about the Zopec medical battery. I said it is an uninterrupted power battery, very small battery, which is compatible to all medical devices and ensures an uninterrupted power supply whilst you're transporting your patients from one unit to another. For instance, you want to take your patients to maybe to do an MRI scan, or maybe to even do an X-ray, or you want to walk your patient outside. Your patient cannot be bedridden for a long time. These batteries come in handy to support the electrical equipment that is attached to your patient, that is giving the support to your patient, such that it becomes seamless. So you have no power interruption. Because remember, while the patient is on the bed, the power supply is connected to the wall, but you want to move your patient from one unit to another. These batteries come in handy to give you a longer run time for you to transport your patient from wherever you want to take your patient to and bring the patient back. It can also support in home care facility. It supports in rehabilitation centers as well. And then it supports at any places that, or any place that requires power backing on your device. Any device that you want to plug on or connect to power supply, you will need these batteries to support you. So as I said, towards the end of the webinar, I'm going to post their details. I'll share it on the screen so that you can take note of it, and then you can reach us, and then we can help you. So we'll give you the direct information at the end of the webinar. Thank you, Rekia, for the question. Any more questions for Dr. Walima? Any more questions for Dr. Walima? If you have a question, you can unmute yourself. I would open the floor for some few questions online. If you want to ask, you can unmute and then you ask your questions. And then we'll move on.
What is the importance of, this is Sharon Armstead, what is the importance of secondhand smoke?
So secondhand smoke exposure actually has more risk of developing all of these lung conditions as compared to firsthand smoke, as it contains more of the chemicals as the tobacco is burned and you're inhaling it. It is very important, just as we promote the quitting of smoking for people, we should also have policies in place that protect persons as well from secondhand smoke exposure, especially in public places, workplace, because inhaling the smoke also put them at risk for the development of all of these lung conditions that I would have covered.
One more thing. In certain countries, like my parents from Guyana, did not smoke, but both of them, my mom had emphysema and my father had asthma, but it came from not secondhand smoke, but mainly from the burning of, the burning of wood, burning of objects. So the burning of objects or wood or whatever, garbage, I think that was important too. I think you mentioned that. So I think we should, can you explain the importance of when you're burning outdoors, indoors, how it affects the lungs also? Both of them had lung disease and they did not smoke.
Okay, so tobacco is the #1 cause, but that doesn't mean it's the only cause. There are other causes that can lead to the development of COPD or the development of asthma or the worsening of asthma. So you also have in rural areas where you see burning of garbage. So by inhaling, chronic exposure to the inhaling of that smoke can lead to acute lung injury, and if prolonged, could lead to remodeling and chronic lung changes. In the city, you have more exposure to pollution from like factories and so forth. So again, inhaling those can also put you at risk for the development of lung condition. And there are some persons who would burn wood to cook on these stove or fireside. They too are at risk. You also have to consider people who have occupational exposure where they're constantly inhaling smoke. For example, welders, people who are farmers and they're burning fields and these things. They're also at risk for developing this condition as well. So we would say anything that you can probably smell can put you at risk for lung injury. So any chemical smoke that you inhale can cause that inflammatory changes in the lungs and the whole cascade of lung changes, resulting in either acute or permanent lung damage.
Okay, so a question came from the Q&A. It says, from Rikia again, she said, what are the consequences for an asthmatic patient living with a smoking partner?
So unfortunately, what we would normally, the consequence for that is that you're having smoke exposure and you're even more at risk than the person who's actually smoking. But the best approach to dealing with this, one of the best approaches to dealing with this will see that your partner and yourself get counseling. So you can, I don't know what is your local country guidelines with regards to this, but it's the best approach will be for both of you to get counseling on smoking, on him getting counseling on smoking cessation and help to quit smoking. And they can also, if he's not going to quit, then you guys can develop ways in which his activities are not going to affect your lung health.
Yes. Okay. Looks like Rikia raised the hand again. So Rikia, this time unmute your microphone and ask your question.
Okay. So, okay, I'm coming.
Yeah.
Good afternoon. Good evening.
Yeah, good evening.
So, I thank Madam Bibi for the presentation she has made. And I want you to excuse me because my English is not so good. I'm a Francophone. So I'm
Don't
just
worry,
trying.
we can still hear you.
Okay.
Yeah.
Okay. So the question I've asked about the smoking partner is my own story because it's regarding my husband who has already passed away due to this smoking because he has I think he smoked a lot, and the same day he passed away because of this, I think, embolia. They discovered that there's his lungs has been attacked, and it's at the very, very, very last stage. So without being sick, he passed away the same day. So I'm a asthmatic person living with him before, but I discovered that even after when he passed away, my asthma is worsening because now I'm even developing. I developed what they call angioedema. I think that I have even swelling in my throat and on my face. This is what has been discovered to me recently. So I don't know, is it related to that smoking or is this something else? I don't know if you understand what I'm saying.
We understand your question, Dr. Walima.
Okay, Kia. First of all, I'm sorry for your loss, and thank you for your question. So your angioedema, most of the time, angioedema, especially the face, lips, and so forth, it's most likely an allergy-related cause. Um, I don't think that is related to your asthma and the exacerbation of your asthma. So asthma and asthma exacerbation could have been from your husband and being exposed to the secondhand smoke, and thus you would have developed um, more severe lung changes or lung damage. So my best advice to you would be to see your physician so that they can do a lung function test to see what's now your new lung function. That's one. Second, maybe a CT scan to see if there are any severe changes, permanent changes, irreversible changes to the lungs. See if you've developed any fibrosis or remodeling to the lungs, and also a review of your medication and education as well. So education session will go through, the asthma educator will go through with you to identify triggers. So you could develop new triggers in addition to the ones that you're already aware of. They will go through with you your inhaler technique. Your doctor will assess. Maybe the
Okay.
medication you have now is not the same, and so you need to either step up your dose or change your medication in order to get control. And it could also be a reason why you're now exacerbating. So if it's lung damage because of smoking, you may require a step up of your medication. But remember, asthma exacerbation could also be caused by other things. It could also be an allergen that's wrong that's causing your exacerbation. It could be induced by stress from losing your husband. It could also be infection in the lungs that's also causing the exacerbation. So my best advice in that area will be for you to visit your physician so that they could find the cause why you're now having a worsening, you're having worsening episodes of your asthma, and you can get tailored management or treatment. With regards to your angioedema, one of the most common cause will be allergen associated, especially in asthma patient, because there is a close link between allergies and asthma. However, there are other causes as well. So again, I would advise you visit your physician and so that they can see this cause.
Okay.
Thank you, doctor.
All right.
Thank
Okay,
you
so
so much.
thank you,
Yes.
Rekia,
You're
for your
welcome.
question. Thank you.
Yeah.
Okay, so there are some few questions coming up. So from Xavier, he says, what's the role of respiratory therapists in tobacco cessation programs? What is the role of respiratory therapists?
Okay,
So
so sorry, you're
please go
finished?
ahead.
All right. So respiratory therapists, I would say, have one of the most significant role in tobacco cessation. So one area, again, that respiratory therapists play a vital role is in asthma COPD education. So they're the first encounters of patients with asthma COPD. They're the ones who are sitting and having that one-on-one conversation with their patients. So as part of their asthma COPD education and action plan, they can go through the BPI that I just went through to assess why the patient is smoking, try to help them quit smoking. And if at that level it cannot be managed by the respiratory therapist, then they could refer for further specialist intervention. That's one aspect in which respiratory therapists can help in smoking cessation, but respiratory therapists are always encounter with respiratory patients. So not only during an education session, a formal education session, you can actually educate the patient on quitting. Anytime, actually, you can take that opportunity to have that discussion with your patient. You've noticed that they're smoking, or you know that whatever is there, one of the trigger or one of the causes because of smoking, you can sit with that patient, have that education session, elicit if that patient want to quit. It may not be in your area that you're working in. For example, if you're in a critical care respiratory therapist, for example, um, or you're working in another area. It may not be your specific area to actually initiate a treatment plan, but after having that discussion with that patient and you discover that yes, this patient wants to quit, or even the patient doesn't want to quit, you can further recommend that patient to go and get help from the persons who are involved in the education and the counseling session and the treatment and management in smoking cessation. So I would say respiratory therapists plays a vital role because they are the person who come in contact with anybody who has cardiopulmonary diseases, regardless of which part of the hospital, regardless of age. So it may be a neonate. You don't need to do the counseling. Obviously, you can't do the counseling with a neonate, but or 5-month-old baby, but the baby might be there for respiratory distress because of mommy or daddy smoking in the home. So as a respiratory therapist, you can identify that, you can have that talk with mom and dad, and then refer them to the appropriate persons that can continue that counseling and continue working with them. So get the parents to quit smoking, or whoever is smoking, get them to quit smoking so that it can improve their respiratory health.
Thank you very much. And that is why the Africa Respiratory Care Association has been formed to enhance respiratory care education across the continent of Africa and the world at large. Okay, so kindly participate in our series of our webinar series as it comes, and then you'll be educated on the role that respiratory therapists play in disease management. Okay, so we have questions from Dr. Karen Shell. She said, do you have any information on exposure from offloading from clothing? Example of a child being held by a person who smoked outside.
Okay, so that's third-hand smoking. Third-hand smoking is basically where the tobacco product that cannot be degraded, the residue stays on your clothes or even on the wall or the curtains or the furniture, wherever the tobacco residue settle. That too can increase risk for respiratory diseases, and it also put the persons or the individual at risk for developing any tobacco-related diseases. Children are more at risk because their hands touch everywhere, and then they tend to put into their mouth, over their faces, and so forth. So they are more at risk. And of course, holding a child close to you where the residue is on the clothes, or having them sleeping on a bed where the residue is at, or a sofa, it does put them at risk to inhale those particles and risk for acute lung injury and damage.
Okay, thank you. And then from Ramdale saying, he said, thank you, Dr. Bibi and Ms. Bender. I'm more educated on lung health. So thank you so
Welcome.
much. And then Maha is asking, is there a noticeable difference between how smoking affects men and women in terms of lung function decline or treatment response?
So I'll be honest that I don't know the answer for if there is a more predisposition to men versus women. However, from statistic, it was something that was most common in men. But however, now that statistic is actually equalizing because of the increased risk of smoking in women as well. So before, it was something that was more prevalent in men. And so, however, because of the more increase now in women, it's basically the same. With regards to actual comparing the lung function deterioration in a man versus a woman, which is more which you will see more deterioration in, I do not have the direct answer to that question. However, I do think that deterioration will depend one on your genetic breakup and your exposure, meaning what you're using, how much of it you're using, and how long you're using it for. So if I have a man that is smoking for 1 year, but he's smoking maybe twice a week, compared to a woman who is smoking every day for 1 month, the lung function in these two persons may drastically varies because of all of these different variables. So I would say that it all depends on exposure, what you're using. If you're using the hookah or the e-cigarette, or you're using all of them, or you're using one of them, and how much you're using and how long you're using it for. It will determine your lung function.
Okay. All right. So lastly, I want to say a big thank you to you. But for Madam Rikia's question, it says, so you can, Madam Rikia, if you can hear me, you can also contact Dr. Ngozi Ibe to also assist you. She is the founder of the Global Asthma COPD Outreach, and she can also help you. She's also the director for advocacy for the Africa Respiratory Care Association. In case you are not able to reach her, you can also reach her on info@africaresp.org, info@africaresp.org, or ngozi.n.eb@gmail. So I will
Okay,
send
I'm
it to
trying
you.
to write.
Don't
Okay,
worry, I'll
okay,
send it to you when
okay.
yes, so just we'll send it to you after the webinar series. So without much this is where we close the curtain on the education on lung health with tobacco. So we have to encourage people to stop smoking, but do it empathically, do it with care, do it with love so that they don't feel neglected. Yes. So as part of the World Tobacco Day and as members of the Africa Respiratory Care Association and participants of these webinar series, this is an advocacy platform for you to spread the news for people to quit smoking. Now, without much ado, I want to share the details or the information about the Zupec medical grade battery because our viewers or our participants are requesting for, and I kindly take this information. If you can see my screen, I want to show you how the battery looks like. It's very small, and this is how it looks like. And as I said, if you're in Africa and you are a hospital procurement officer or administrator that needs these kind of batteries or other medical equipment that supports patients, you can contact Zopec on through JC. JC is the country rep in South Africa on +27662332941 with the email address, and he is also with Pulmonary. Pulmonary is one of the vending members of the Africa Respiratory Care Association. You can also contact Africa Respiratory Care Association directly on info. So, Ricky, this is the information here. In case you are not able to read Dr. Ngo's email, you can screenshot this. This is info@africaresp.org. And to anyone that has questions for Dr. Walima Bakus, and you can reach her, you can directly reach her through info@africaresp.org. And if you want to know more about what the Africa Respiratory Care Association is doing, kindly contact us or go to our website at www.africaresp.org. And if you are a company that is participating or an industry that wants to support the Africa Respiratory Care Association, kindly click on the support or donate button to support the Africa Respiratory Care Association to promote respiratory care excellence across Africa. So this is where we say thank you to our presenter, Dr. Bibi Bakus Ali. Thank you so much for making time to educate us. We have really been enlightened. And I also want to say a big thank you to our proud sponsor, Zopec Medicals. And last but not the least, our proud participants who have learned something today. Thank you all so much. We look forward to seeing you in our next webinar series. Until then, it's bye.